Well, good afternoon, everybody. Welcome. As you come into the room in our virtual space, if you don't mind introducing yourself in chat, that would be great. We'd love to know where you're zooming in from, your role, organization, location. My name is Laura Vanderhill, and I'm zooming in from Massachusetts, and I will be sort of your host today. And once we get started, we're just going to give everybody like one more minute. And then we'll dive in. And for those of you who have been with us throughout this series, we've been focusing on prevention and management of patients with chronic conditions. We started back in February. And today we're just going to take a little bit of a deeper dive looking at cardiac rehabilitation. So glad you could join us. And it looks like a couple more people have come in, so that's great. We'll dive into the material then. All right, next slide, please. All right, so for those of you who maybe are new to the iPro QIN-QIO, we cover in partnership with Health Centric Advisors, which as you can see is where I'm from, Clarent and iPro, to cover much of the Northeast. And we are the Quality Innovation Network, Quality Improvement Organization, in contract with CMS. And we cover about 20% of the nation's Medicare fee-for-service beneficiaries in terms of really trying to advance quality of care. Next slide, please. So as you may have heard, our session is being recorded today. We do ask that you keep yourself on mute just to kind of help, with background noise, that kind of thing. But definitely, be active in chat. Let us know, as I said before, where you're coming in from, and then let us know if you have any, questions as we go through today's material. Next slide. So as I mentioned, this is sort of wrapping up our first phase of our chronic conditions learning series. We actually talked a little bit about hypertension and cardiac rehab back in February when we had Haley from Million Hearts come and talk about the Million Hearts change package and other activities that they do. And then we talked about chronic kidney disease and diabetes. And so today it's really going to be looking at referrals and participation with cardiac rehab. Next slide. So today we're looking at best practices and some evidence-based tools and interventions, looking at, some of the health equity. There are definitely disparities when it comes to cardiac rehab, participation and enrollment. And then we'll also look at some of the iPro QIN-QIO resources that we have to help support the work. Next slide. So what is cardiac rehab? For those of you who are new to this or you're, maybe looking to learn more, we, always just kind of want to level set. And so it is a medically supervised and multidisciplinary approach, secondary prevention program. And it's usually 36 sessions over about 12 weeks. And as you can see in the diagram on the side there, that it's not just exercise, right? There's so much to it, and it's a lot of benefits with having that multidisciplinary approach, looking at nutrition, medication, psychosocial support, and it also has the added benefit of, you get some peer support as well. And as you can see here from this list, it's designed really to help with stabilization, with prevention of complications, and improve, the overall quality of life and functional status. Next slide. So here's a list of, cardiac rehab eligibility. Not everybody, of course, is, going to be appropriate for the program. So these are some of the, either cardiac events or diagnoses that, are most typically, referred to cardiac rehab. Next slide, please. So as I mentioned, there are several benefits to cardiac rehab. And, the evidence has shown that it actually reduces the risk of death and decreases hospital readmission. And, in addition to, quality of life and functional status, it also can improve with medication management and adherence and patient's mood following a cardiac event or cardiac diagnosis. Next slide. So why are we here today? Well, we're here because unfortunately, cardiac rehab is still underutilized. It has a lot of benefits, but there are also, different barriers to patients being enrolled and completing the full program. And so we're really going to be looking at some strategies today to help with the referral process and, helping to sort of motivate and engage patients and help them participate for more than one session, right? So next slide, please. So here's just a little bit more data around enrollment for Medicare fee-for-service beneficiaries. And as you can see, it varies. So even just within the IPER region, anywhere from about 15% to 39%. And so we are looking to improve this, across our QIN-QIO region, to help, have it be that more people could benefit from this program. And so with that, I'm going to introduce our speaker for today. Next slide, please. So we are thrilled to have an expert with us. Kate is the director of the Massachusetts General Hospital Cardiovascular Disease Prevention Center, which has two programs, both the traditional and the intensive model. And she is also the past president of the American Association of the Cardiovascular and Pulmonary Rehabilitation Association. And she has a lot of great experience. And so we're thrilled to have her here today. Kate, I'm going to turn it over to you.
Awesome. Thank you, Laura. And I want to thank Karen as well. They've been great in talking with me and getting me prepped for today. So listen, thank you all for having me at your meeting. And I can think of no better audience, frankly, than a group of quality improvement professionals, because certainly, as you can see from some of the preliminary introduction remarks that Karen made, or Laura made rather, if we could bottle this cardiac rehab effort in a pill, it would be a blockbuster. and what I mean is, anything that can reduce hospitalizations by 28% and reduce readmissions, in a similar fashion, would be hugely successful if we could make it easy for people to both get it and consistently use it. And so patients it's much easier for people to help people change or add behaviors than change behaviors. So part of our problem is, yes, referral and getting people to our door. And part of the challenge is keeping them engaged so that they actually implement and make the changes in the areas that, you saw on the infographic are all of what we focus on when people come through our doors. So we don't have that poly pill. It's good old fashioned advice, counseling, encouragement, hand holding. So let's talk a little bit about cardiac rehab. So you saw the infographic, and really it's 10 areas that we focus on in helping patients get over their secondary prevention event, whether that's a heart attack or having had a stent. There was also one more indication or one more qualifying criteria that I noticed was missing, and that's heart failure. So for patients with really severe systolic heart failure, they're also eligible for referral to cardiac rehab. And they're a really important group to get engaged in this process, because really, what does it focus on? Not only exercise and activity guidelines, but all of the things that go along with helping people feel well. So the psychosocial component, the nutrition counseling, the weight management, helping people understand and control their diabetes a little bit more effectively, getting them and encouraging them and coaching them to quit smoking. So you can see that all of these things are really not easy for people to accomplish, certainly not independently, but even with, some cardiac rehab professionals at their side, they can be challenging. But so important, in fact, so important that many of our national professional organizations that have published guidelines of care have made this a class 1 indication, which is really the strongest recommendation for treatment. And, those cardiac rehab participation and referral is a class 1 recommendation and guidelines for people who have suffered a heart attack or have bypass surgery, have angina. So because we know that the evidence suggests, there's good scientific data suggests that when people engage with rehab, they do well. At a macro level, there's been so much attention lately on this, and I think we really can thank our Million Heart partners for the help that they've given us, in this regard. For years, we've had a national organization, which is, as you heard, is the American Association of Cardiovascular and Pulmonary Rehab. That's a national organization of professionals across the country. Many states, most states have their own state affiliate groups as well for cardiac programs. So they've done a terrific job educating professionals, having professionals network, pushing through legislative initiatives and agendas and priorities to help with all of the important work that we do. But to have a partner and the muscle, of the CDC and CMS helping kind of address the challenge of under referral of patients has been really a game changer and a big help. So Million Hearts, as you know, stepped in early, mid 2000, around 2012 or 13, and had had an overarching aim to reduce cardiac events, 1 million cardiac events. And by focusing in two general areas. One was to optimize care, one strategy being improve utilization of cardiac rehab, and the other building better communities and stronger communities. So from their initiative to actually increase and improve the utilization of cardiac rehab, there's been a number of initiatives and a number of resources that have come from that, which have been fabulous. The first of which was something called the Cardiac Rehab Change Package. And the Cardiac Rehab Change Package is literally that. It's to look at all of the areas where the problems and the challenges exist. So getting people referred to the program. So this change package gathers together rich resources from members across the country and participants across the country that have some best practices around referral, what's worked well for them, how have they been able to accomplish that, and what strategies have they used to improve their own, internal processes. There's a section on enrollment. So once you get the referral, actually getting patients into the program, similar kinds of resources available around, what's worked out in the field. And then finally, adherence, or getting patients once they're in and enrolled through to completion, because at every step in the process, unfortunately, as you saw from one of the earlier infographics, there is a little bit of a drop off. So we may get them in, we may get them initiated, but getting people through to completion remains a bit of a challenge. So the Cardiac Rehab Change Package was released in 2000, probably 18-ish, 19, and is undergoing a second edition and will be released very shortly because we've enhanced and added many more tools and strategies for each of those areas. I think that you have, Laura, a slide that we can show a little bit later about what that change package looks like, but you can certainly find that by just Googling it. It's available online, and it's a really handy resource to both educate yourselves about those areas and what resources exist, as well as to share with other colleagues that may or may not have been able to make it onto the call today. One of the other important initiatives is that there's been this terrific networking group of people that's been brought together through the Million Hearts Initiative called the Cardiac Rehab Collaborative. And that group meets meets quarterly, and it has diverse representation from across the country. And really, there's a whole work plan for what that group is hoping to accomplish. In each meeting, there's experts and speakers and, different strategies brought in to address different aspects of the work plan and help people to, again, network together, work better together to improve the use and the uptick in cardiac rehab utilization. There was also in 2019 a fabulous initiative called Take Heart. And so Take Heart was a combined effort between the CDC and the AHRQ to actually offer actionable program to help programs do three things, really. It was a 10-module program, again, available online. If you just Google Take Heart, you will find all of these fabulous webinars, seminars, and resources that take you through 10 modules to address implementing automatic referral to cardiac rehab for patients, that are eligible. And you saw the eligibility criteria earlier, ensuring care coordination. So just simply placing the referral in and of itself is not enough. Unfortunately, it's helpful if there's somebody or a group or an area within an institution that can help coordinate the care of moving patients from, the point of hospitalization into and shepherding that referral and getting patients into programs. And then lastly, there was a focus on looking at a different way of delivering cardiac rehab so that, bringing patients to programs is certainly been the brick and mortar tried and true strategies. But we've also learned through COVID and other challenges that I'll get to in just a minute, that oftentimes it's hard for patients and almost impossible for patients to avail themselves of a brick and mortar program for a variety of reasons. COVID prevented us from operating programs during, the early portion of the pandemic. And then there are places in the country where there are very few cardiac rehab programs. We call those our cardiac rehab deserts. And so it's difficult for patients to drive distances to get to some of these facilities and some of these centers. So thinking differently about how to really bring the mountain to Mohammed was kind of the thought behind this different model of hybrid or virtual cardiac rehab, if you will. So the Take Heart initiative also addresses implementation of a hybrid program and has some really terrific resources related to that. So all of those things have been fabulous and are kind of at a macro level and really have been useful for, professionals in the field, useful for you when you're thinking about, what role can we play in improving this situation? But there's a lot happening at the micro level, which is where the programs are delivered. And I wanted to share with you a little bit of kind of what we see, in our centers and in our facilities around, what are the other challenges besides, the referral and all? What are some of the barriers and what are some of the things that we're experiencing and dealing with and getting patients into the programs and all? And I think that there's probably 3 important areas that won't be new to you, but we can talk a little bit about, and I'd like to talk a little bit about, how do we address that and what are we trying to do on a more local micro level to, really just manage those barriers a little bit more effectively. And so the 3 would be certainly working with racial and ethnic groups has its challenges. The second being those that are in the lower socioeconomic categories can be a challenge. And finally, some of these rural programs or the areas that I referenced as cardiac rehab deserts. And what's interesting is that the definition of a desert is actually changed. Used to be that there just weren't programs near, some of these states have broad geographic distributions, but very small number of programs. And what happened as a result of COVID is that we actually saw even areas with that were densely populated with cardiac rehab programs, saw many programs close. And in Massachusetts, which is where I am, we had at least 10 programs close over the course of the last few years. So that even though it's an area that's small and, compared to other states in terms of geographic size, the number of centers has closed. So that, in many ways, we're in that same kind of a bind with just not enough programs to go around and patients who are now having to think about traveling distances when they never had to do that before. So we've had to think very, very creatively about how to address that as well. So let's talk a little bit about some of these issues and what we've done about them and how, how you too can be thinking about these and how to help us work better together to address some of them. So when it comes to sort of a racially and ethnic diverse population, some of the challenges in that would be language barriers, certainly as a real challenge with trying to, engage patients and keep them engaged and be able to converse with them in an effective way. So, we are able to use very effectively medical interpreters. Oftentimes with some of the languages that maybe not as frequently, that we don't have interpreters because the languages just that aren't frequently used. We have the ability to use some technology that can help us work a little bit more effectively with patients. And so I think necessity is the mother of invention, and technology has been a huge help in that regard. So we've actually worked effectively with our medical interpretation department here at the hospital that I'm at. And we're developing this, what almost is like an iPad type of I translate, we call it, and we speak into it, and the patient on the other side of us is literally, it's translating as we're speaking in their native language and in what they're able to read and understand. They speak back, and we're seeing on our screen the English translation of what it is that they're saying. So it's kind of this two-way communication device that where we don't have an in-person interpreter, we're able to use this device, which has been very effective and very helpful. I think really the gold standard is to have that medical interpreter available, but there are other ways perhaps of using technology to help in this times when that's just not possible. We try not to use families. I mean, it's not recommended always that we use family or friends. I mean, in a pinch, we've done that, but there is concern about privacy, whether patients will be truly forthcoming and honest and open about some of their responses and feelings. So, we try very hard to use either the medical interpreters or some other technology to help really be able to have that be a free flow of information and have honest answers and a great, a worthwhile exchange. From the standpoint of the other is that we've tried to be very flexible in scheduling so that patients have transportation issues. We're in a city, so getting here, there's all kinds of, as you can imagine, infrastructure around transportation that can be problematic, and traffic and all of those kinds of things, parking, costly. So we try to have programming and timing that allows for people to have some flexibility in what day of the week they come, what time of day they can make it. And our goal has been to make this as flexible as we can be. And early on in looking at cardiac rehab, and when Laura had described, what does the program entail, CMS and Medicare does allow for 36 sessions, but honestly, to get somebody here 36 times is very challenging. So what we've tried to do is bundle that in a way that we combine our education along with all of the other kind of activity and exercise guidelines, so that we're using 2 units or 2 sessions each time the participants come, and we can move them through a little bit more quickly, decrease the number of times that they actually have to visit. And we've been flexible. We allow them to come once a week. We have a model of twice a week. I mean, as I said, we're doing all that we can to kind of meet them where they are and make this service a little bit more approachable and useful and accessible to them. I think one of the big barriers for people of a low socioeconomic group can be that some of the payers have co-payments for cardiac rehab. So, obviously those out-of-pocket costs can be cost prohibitive if they have a limited income or they have limited resources, financial resources, and they have big decisions to make about where to spend those. Anything that we can do to strip that away from them is really helpful. So we've worked a lot with our patient financial services to see if there are ways that we can help people to come up with payment plans or defer those copays. The CMS Medicare Advantage plans do have the capability to waive copays, so we've tried to work effectively with some of those plans to do that. So that, we're taking that barrier, at least trying to address that barrier as well as we can. By combining sessions, copays are assessed on a calendar day visit, not on number of visits in a day. So by combining visits, we can also cut down somewhat on their out-of-pocket costs if they're only coming to us, perhaps, 18 visits as opposed to 36 visits. That does help cut down on some of those out-of-pocket expenses for them. And finally, let's talk a little bit about the rural challenge, both either true cardiac rehab deserts or places such as the one that I described where we are, and we just have program closures. So hybrid or virtual cardiac rehab, really the advent of COVID was what really forced us, as I said, to think a little bit out of the box. I mean, all of a sudden, literally I'll never forget March 17th, 2020, boom, the doors were shut and locked. And, I told my staff, you have to go home, you have to work from home. And, we scrambled to try to parcel together and put together some kind of a hybrid approach or, outbound approach to people in their homes. So over the course of the last few years, we've gotten very sophisticated and done a really good job with really trying to bring to people in their homes what we provide in our brick and mortar centers, and tried to model what we do at home similarly to what we do here. So still offering the guidance around exercise, the psychosocial counseling, the education, all of the risk factor modification information. And we've done that with two-way audio visual. So they're at home, they have their device open and they're on their exercise equipment, and we're sitting just as we are right now at our desks with our monitoring system available to us to be entering data and information about them. And we're able to work very effectively with them. And I mean, we've established safety protocols and all the things, but what you should know is that, the number of issues in cardiac rehab from the standpoint of safety or untoward events or adverse events have been very low. And, part of that is because we have great professionals that are very, very good at assessment, evaluating people ahead of time, trying to, head off trouble at the pass, and encouraging patients to let us know, if they're not feeling well or if there's something that has come up. So that was a concern, honestly, by the staff about how safe is this going to be to have people in their homes. But, by using similar work processes and assessment techniques that we would if they were in person with us, we've been successful in implementing both not only locally here, but across the country. There's great success stories with implementing virtual cardiac rehab. And some of our colleagues in Michigan have even been able to negotiate with third-party payers such as Blue Cross of Michigan to get them to continue to cover and pay for hybrid cardiac rehab. So we've had some great success stories and some great, it's been very beneficial for people that have not wanted to come in during COVID, have not been able to avail themselves, because of geographic challenges, as I mentioned, and it's worked quite well. So we were afforded the ability to do that through the pandemic and the public health emergency. With that ending tomorrow, right? Tomorrow's May 11th. We won't, unfortunately, our ability to do that was only allowed through the PHE. So with that ending, for our Medicare participants, we won't be able to continue to offer a virtual option because the coverage payment period will end with the PHE ending. But as I said, with third-party payers, they certainly have complete flexibility in their decision-making around who and how they'll pay for cardiac rehab and in what circumstances. So, we're still going to continue to offer it and work with our third-party payers to make certain that, they will continue to cover that even beyond May 11th. So I feel like I'm talking a lot. I know, I don't know if there's any chat questions or not, but certainly want to leave time for that. The other thing that I want you to know is that there are two legislative initiatives that I want to bring to your attention and maybe seek your help with, getting some support for. The first is HR 1406, which is a bill to establish permanent coverage of virtual cardiac rehab. And so, I'd urge you to be in touch with your congressman and talk with them about HR 1406, which, and how important that would be to help us continue to strip away some of the barriers that exist now in getting patients to avail themselves of our services. The second is HR 955, which we're calling sustaining outpatient cardiac rehab and outpatient services. And so what we find now is that if a cardiac rehab program is not on the hospital property and they relocate to an offsite, which many programs have had to do to make either to get larger, to increase the size of their facility so that they could accommodate more patients, or to move away from the hospital where the space is needed for other kinds of more acute care management. And they move some of the, outpatient activities off-site so that they can continue to offer those, but just in a different area. There's actually a negative effect on our reimbursement if we move too far away from a hospital, because now we're considered off-site and the reimbursement actually is halved for programs that are not located within 250 yards of the main facility. So HR 955 says, basically takes away that negative impact, that negative economic impact by relocating programs or allowing programs to move, still be hospital-based programs, but move geographically to spots that they can either expand or just allow for other use of the space that they may currently have at the hospital. And because some programs are stuck in their spaces right now, not able to expand because they just don't have the room. Yet moving them into a bigger space would have this direct negative impact on their bottom line. So, it really does present quite a challenge. And that changed in 2015. prior to that, it didn't really matter, the distance from the hospital. But in 2015, there were some other services that were kind of gaming that geographic location, and hospitals or CMS caught on to that a little bit and realized that some of these facilities, some hospitals were moving some things such as surgery centers and MRI centers and some of those other kinds of things that are very lucrative off-site, and they were able to still bill at the level that they were when they were in hospital services. And so, to sort of counter some of that, we had this special stipulation come in about this on-site, off-site type of reimbursement. So I think that the intent was not at the time to harm programs such as, cardiac and pulmonary rehab and, outpatient physical and occupational therapy, but we are kind of a byproduct of that. And so HR 955 tries to correct that for small services, because there is sort of a limit as to how much those services can be billing on an annual basis. So your help in both regards, both with the virtual rehab bill and with the sustaining outpatient services bill, would be terrific. So if you're so inclined, love for you to talk to your congressmen and women about that. So I'm going to stop here and let Laura and Karen know if there's any questions or issues that have come up, or if there's anything that I said that's unclear. I'd be happy to clarify any of that.
Kate, thank you so much. I know I learned new things just listening to you. You know so much, and so we just thank you so much for that. And as people are thinking of questions, we'll go to the next slide, sort of our chat in slide. We do encourage you to let us know if you have any questions for Kate. And while people are thinking about that, I was just thinking related to like the hybrid and the virtual programming. I think I heard it through Take Heart that, we're actually not able to meet, the need in terms of, everyone that would potentially be eligible for cardiac rehab through brick and mortar, right? And so I think this is where, I'm really hoping that the third party payers and others will, certainly stay in this sort of virtual and hybrid space, because I think that's really where we can, not only in terms of breaking down barriers for patients, but build capacity. Is that kind of what you've been hearing as well, Kate?
It is. I mean, I think that's a really good point. I'm glad you brought it up, that if we are successful in increasing, the goal is to increase referral to at least 70% of eligible patients. As you saw in the early infographic, only about 28% of eligible patients get referred. To triple that to 70%, would definitely strain, the existing program. So obviously thinking creatively and being able to deliver the service creatively would help us address that and prevent us from having a huge backlog, at our centers. So maintaining this virtual delivery would be a substantial help in many regards, that being one of them. So thanks for bringing that up. That's a really good point.
Sure. It looks like Angie has a question. Thanks, Angie. So what is working well? I think you did touch on this, but we want to hear more. So what is working well for referring patients to cardiac rehab? And is it automatic referral in the EHR, care coordination? Is there any sort of, magic, strategy that you had at MGH that seems to be working well?
Angie, thank you. That's a really good question. And based on what Laura said, I want to tell you it's all of the above. So the one thing that electronic medical records have done is with this automation, where truly when there's a patient in the hospital, who's hospitalized with one of those qualifying criteria, you can tee it up such that there is an automatic process that goes into place that recognizes that that's an eligible admission, that admission criteria is eligible for this outpatient cardiac rehab service, and then starts that process of sending the referral electronically to the receiver, who would be the cardiac rehab program. So that's been a huge uptick, and we've experienced a huge uptick in referrals through that automatic process. And there's a number of ways that you can structure that in an institution. You can do that automatically, which means that referral is going to go. If you come in with these criteria, you're automatically going to have a referral go off. And there are some people, not all patients, are going to be eligible, or they're eligible by admission criteria, but maybe there's other variables that prevent them from being able to avail themselves of a program, or they're just not able to participate. So there is a way to opt out. So that's one strategy. The other is not so much to have it automatic for everybody, but to remind providers that, hey, this person is eligible for cardiac rehab. Don't forget to put in that referral for cardiac rehab. So, with every step that we utilize to remind people, those nudges and those electronic kinds of reminders are very useful in getting people referred. Another and this was what Take Heart really focused on, was this care coordination, bridging that gap from hospital to outpatient is real important. And if you have an identified liaison or some identified resource group that can help do that, the better off you are. And that's yet one more strategy that increases the chance and the likelihood that you're going to get people through your doors, or, on your virtual screens, if you will. And it's also important that those resources or those liaisons get to work quickly, because what we found through research and what we know is the longer that patients are at home before they're contacted or before they have that appointment in their outpatient cardiac rehab, the less likely they are to actually engage. So the notion here is get the referral in as quickly as you can, which automation has helped. Reach out to the patients as quickly as you can, which is what the liaison or the care coordination can do. And then the program's responsibility is to take those patients that are sent to them or referred to them and get them enrolled as quickly as possible. So they need to be looking at their own internal processes. We can't have this great feeder funneling into a very small, funnel. We have to have sort of these processes that work efficiently and effectively. So there's been a lot of work on the part of our national organization to help programs work and think about efficiencies and changing processes to bring people in a little bit more quickly. So those are all the strategies. I mean, we've sort of attacked it on a number of levels. And what we've done here is, we've tried virtual evaluations with patients. We have in-person evaluations. We have group evaluations. So we have actually morphed ourselves in many different ways to do our part to bring in as many of those people that we have referred. The other is that, when you're in a big metropolitan or, city center such as ours, that we have many patients referred to our facility for special care and special interventions and treatments, but it just isn't reasonable for them to come back to Boston for cardiac rehab. They don't live in Boston. They're not going to drive to Boston. So we offer the service and work with our internal providers and work to get those patients. We are the care coordinators. We work to we have a category called external cardiac rehab, meaning the provider recognizes that those patients aren't going to necessarily come into our program, but they'd like our help to get them to an external program. So we do get these, what we call external referrals to external cardiac rehab. And then we maintain a list, and, we have a national directory. There's all kinds of online resources to help you find programs in other states that we then do the reach out and then facilitate that communication to those programs that are outside of even our state boundaries sometimes, to get these patients referred over and get them matriculated in really a more reasonable, spot for them, a more something that's far more convenient. So all of those are the strategies that work. I mean, sort of everything works, and each one of them is helpful. Combined is when you really think through the entire process of referral, that bridging from inpatient to outpatient, and then getting patients in the door quickly. All of that is what needs to come together to work effectively and to get as many people in as possible.
Right, absolutely. I think that's where, it's not going to just be one thing,
Right.
it is a combination of things. And I
Right.
think, Take Heart does such a great job in their modules of breaking it down, but they also say, like, you need to have each component in order to really, make sure that as many people as possible can benefit.
That's right.
Absolutely. Absolutely. And,
and I think the other piece of that, and that's something that I left out that's important, is the message matters, and who the message comes from matters. And what I mean by that is, we know that one of the single most successful strategies to get patients to enroll in these programs is if their physicians tell them that they want them to consider it and they want them to do it. And so, I mean, I think that's really key, is how it's presented to a patient and who presents it. So for instance, when I get a referral, I don't necessarily say, you know, I've got this referral. I'll oftentimes say, your physician, Dr. So-and-so, has asked me to give you a call, because effectively they have, right? They've sent me a referral and they're saying, we want this person in your program, or we want you to help this person find a program closer, you know, that would be a little bit more convenient and manageable for them. So the way that I open that dialogue is knowing that what the catch is, and what, you know, what's going to be because the person doesn't know me, but what's going to capture their attention is if I say to them, your doctor has asked me to do this and wants you to consider this. That becomes more personal and much more meaningful. So, so that's another really important step in the referral process, is to make certain that they're aware it's at their physician's recommendation, you know, that somebody's making this reach out to them.
Kate, this is Karen, and I'm glad you brought that up, because I know we spoke a lot about that prior to this session. And I do think it's really valuable, and I was going to ask you to talk about that. So thank you.
Yeah.
My other thought quickly is, you mentioned heart failure. And as we look at we call them care transition reports that we send out to the state, and we have state level reports, you know, heart failure is one of the top 1, 2, or even 3
Right.
categories that bring our patients back in to the hospital. So I think it's an opportunity to think differently for our heart failure patients that may benefit. Are we, you know, is there awareness of that? And are they at the level that they could be referred from the doctor? And how do you have those conversations? So I'm glad you brought that up, because I think it's kind of triggering some thoughts in my mind on how we could be helpful to patients that we may not have even thought about before for
Right.
cardiac rehab.
Right. And so, you know, what sort of helped enhance the referral of heart failure patients to cardiac rehab was the HF Action study, which was heart failure action. It was really, you know, putting patients in programs, secondary prevention programs such as this, and showing, you know, that improving physical function, decreased hospitalizations. I mean, all of the things that we do have these fabulous outcomes. And it was a strategy, it was a study that was done on patients with really pretty bad systolic heart failure, that all of them had ejection fractions less than 35%. So when CMS decided to cover cardiac rehab for patients with heart failure, they baked that into the coverage criteria. And by baking it in, I mean, they've made this heart failure criteria be those patients with ejection fractions of less than 35%. So we do see and get many referrals for patients whose ejection fractions are a little bit higher than 35%. So we have to be a little bit thoughtful about that. And so a couple of things I want to say about that. It doesn't mean that we only see patients whose ejection fractions are less than 35%. That is definitely the eligibility criteria that CMS has. Private payers, again, have great leverage and flexibility in their policies, and will certainly be worth a conversation with those payers to say, you know, somebody's ejection fraction may be higher than 35%, but their physicians want them in the program, and this is how we can benefit them. The other is that many patients hospitalized with heart failure will have a type 2 heart attack. A type 2 is called a type 2 non-ST elevation heart attack. And so presto, there's your qualifying criteria. So even if by their ejection fraction they're not eligible, many of them, because it puts a little bit of a strain on their myocardium, have this release of troponin and will have these kind of evidence of, even though it doesn't do great damage to the myocardium, it certainly has released the enzymes in it, and that's a supporting criteria. So we'll use that non-STEMI type 2 heart attack to actually be the qualifying criteria. But really, we know it's the heart failure that's the issue, and those are the kinds of things that we address when they're with us. So understand that, you know, it takes a little bit of sometimes a little bit of clinical work and digging to, you know, figure out a creative way and still, you know, acceptable way to get these patients in the program. Because there isn't anybody that doesn't benefit from cardiac rehab. Let's face it. I mean, who can't benefit from losing weight, exercising, stopping smoking? I mean, all that we do makes sense. It's just, how do we make certain that they're going to have this paid for, so that we at least don't have them incur any major economic setback as a result of their participation. So, so heart failure is where we, sometimes have to look, a little bit harder to see how we can actually get them in and get them matriculated in the program.
No, that was really helpful. Thank you. And,
Sure.
when you think about this too, we're so backwards because, EF out of 35, if you can get that person at 50, maybe they won't get,
Right,
a lot,
right,
build up more endurance to keep themselves stronger. So,
I mean, it really, and that's, it was the study, and really CMS is thoughtful. I mean, they like to, cover things that have good science behind
Yes.
them, and that, and so you can't fault somebody when they've been thoughtful about something. It's just that it does somewhat tie your hands, right? So, but we know that there's like patients with preserved ejection fraction, HFpEF, can of course need the help that, those patients with HFrEF need. But I think that data is just, I think it'll come. I think, there's a number of initiatives now and some studies that are trying hard to show that there's benefit in these programs for the HFpEF population. But until that happens, we kind of have to be a little bit creative about how we might be able to be inclusive of those, that group of people as well.
great. Thank you.
Great. Well, thank you so much. And, we're just going to cover a few more things. And if people have questions, definitely feel free to jump into chat and we, can certainly get to those questions. But I just wanted to kind of add on to what Kate's already talked about around health equity. Next slide, please. Yeah, there you go. Perfect. So, just shining a light really on some of the disparities. We know from you can see that, this is from Million Hearts. They really looked and they know that we have sort of a, disparity for both gender and race and ethnicity. And, I think it's especially if you go to the next slide, you can see that Black women are 60% less likely than white women to be referred and to enroll. So I would say they're really probably most at risk of not being connected with cardiac rehab. And then you can see here that, for both, Asian, Black, and Hispanic individuals are all, the probability of them attending is less, the percentage is less compared to whites. And then as, Kate was saying, it's so important to keep, from when they're referred to when they, participate, as short as possible of a time frame. And you can see here that it's much longer for Asian, Black, and Hispanic patients. So just sort of something to be mindful of as we are looking at strategies and how to connect better with patients. So next slide. So as we've talked about, its location, its income, language barriers, right? And then also, older adults are often, under-referred as well. And so I think it's, sort of looking at it, sort of across these different, social determinants of health in terms of how we can address, some of those barriers. And I know Kate had, some great suggestions in what they've been doing at MGH. I really like the Translate technology that you mentioned. That's great. Next slide. So, just sort of a quick overview, of some things that we've been talking about throughout the series is, looking at making sure there's a screening for the social drivers of health, health-related social needs, and then different ways of addressing that. And I know Angie shared a bunch of our resources already in chat. And I know just from talking with other cardiac rehab programs, sometimes it's been gas cards or parking vouchers. I know Kate mentioned, support with those co-pays. And then of course, the virtual options. It's just sort of different strategies to help, address some of those health-related social needs. And then I think, other strategies, we have shared decision-making tools, motivational interviewing, kind of takes all of the above, right? And then I also wanted just to mention, we do have lots of information here at iPro on the cultural and linguistic, appropriate services standards. So if anyone's looking for more information on class, in terms of how to, like an action plan and to implement that, we can certainly help. And then I did want to mention the women-focused CR. So there is a whole list of resources at the International Councils. I have the link here, and these slides will certainly be available to everyone afterwards. So if that's something that you're interested in exploring, some have seen that sort of tailoring different aspects of the program more towards women can be helpful. And then I think it's building that trust and those connections with communities to kind of help people know about cardiac rehab. And if you go to the next slide. So here's some of the resources, and specifically in terms of the community-based side, I do recommend our LINKS portfolio. LINK stands for Local Interactive Network of Knowledge Sharers, and that's really just the Medicare fancy acronym for community-based organizations. And the portfolio that we have here has a fact sheet that's just very basic introductory information for people about what cardiac rehab is. And then we also have presentation slides as part of that. And it can be great to be used at, at community center if you're really trying to get the word out and help people understand what it is and the benefits of it. And then we have a couple other resources here. So, the list of programs in New England can be really helpful for, finding that program that's more convenient for the patient, for example. All right, next slide. So here's just a look at the guide that we put together. Really just pulls together everything that we're talking about. So it has, references to the Million Hearts Change package, and also Take Heart. So there's a lot of good information in there. It's just kind of puts it all together in one 11-page guide and just kind of make it more convenient for people. Next slide. And here's just a couple of snapshots of the portfolio that I mentioned. So you can see we have a sheet that talks about that talks about sort of how to use the materials, and then what the fact sheet looks like. And then on the next slide, we just talk about some of the additional resources that we have really around social determinants of health and health equity as well. Next slide. And so as Kate mentioned, we're really excited that A Million Hearts is going to be giving us the next edition of the Change package, probably in June. So, we're excited about that, and we'll certainly be updating our tools once that new Change package is out. So keep an eye out for that. Next slide. And here's just the Take Heart information that we've been mentioning if you're new to it. So, here's the link, and I think I put it in chat earlier, and it's just a great way to learn more about some of the great strategies we talked about. Next slide. And here's our whole team. So we do encourage you to reach out if you're, not just about cardiac rehab, but if you are looking for support and resources and tools, data, related to chronic disease prevention and management, feel free to reach out to us. We love to hear from you, and we're here to support your work. Next slide. So this sort of wraps up our initial learning series, but we're going to be having more coming up in August. So stay tuned, and you can check back on our calendar of events to see what's coming up. And we look forward to seeing you again in August. Next slide. So when we send out the link to the slides and the recording, we'll also be offering an opportunity to fill out a quick survey. We'd love to hear from you. Let us know what's working and what's not, because we definitely want to make sure that the education we offer is connecting with what you're looking for. Next slide. Here's our website. You can get access to all our resources through our homepage. If you just go to About Us and then click the QIN-QIO to take you to the resource library. Next slide. So thank you everyone for your time today. Thank you, Kate, so much. I hope others learned as much as I did, and I appreciate your time today.
Thanks for having me. Appreciate it.
Thank you so much. And thank you everyone for your commitment to your patients and to quality improvement. We couldn't do it without you. It all takes a village. And so with that, I'm going to give everyone 5 minutes back to their day, and I hope everyone takes care.
Thanks.
Great. Thank you so much. Thank you.
Bye-bye.
Bye now.
Thank you.